Is the screen showing? Good. Okay. Hi, I'm Sibley. I'm a primary care physician. My official title is bilingual staff physician at International Community Health Center. A quick introduction about Asia. I hope some of you have worked with Asia before. It is an organization start in 1995 by four Asian women who wants to improve the quality of life for Asians in Ohio. Since then, Asia has developed into a big organization. The biggest one that serves the AAPI, American AAPI population in Northeast Ohio. Asia has 9 divisions. One of us is the International Community Health Center. We also do children, youth, and family services. One of our big program is the after-school program called ISEP. And then the aging adult services, we have like a social organizations for the older adults. We have professional interpreting service, and we have a lot of trained medical interpreter, including me. And then of course, legal service. Ahimsa is for our victims of violence, domestic violence and human trafficking. And then sustainability service, which is important. And then our CHW has a lot of connections with other organizations in the Cleveland and Akron area. Our International Community Health Center started, I think, right around the time when the Affordable Care Act started in 2013. In the beginning, we only have one clinic part-time with one bed with volunteer physicians. Our official opening was 2015 in Cleveland, and since then we have started a clinic in Akron and in Cleveland. And I think from 2013 to 2015, we served over 30. We served about 30,000 clients, and I'll have better statistic next time, but we have interpreters that can interpret more than 55 language. More than 80% of our staff are bilingual or multilingual, and not just in any language, but the language that our patients need. I was with Asia for the past 10 years doing different things. I was in CHW, I was doing work for medical assistants and community outreach and screening and vaccination. And now I am the staff physician. I started this January. So I'm very, very grateful for the needs, because I can use a lot of advice and help with resources and just instructions. So thank you. My case is a 71-year-old female. I've seen this patient once, and I talked to her on the phone once. Just some background. She was a refugee in Nepal for 20 years. So she was in the camp, never get to see the outside. She moved to the US in 2012, 10 years ago. She couldn't get citizenship. She moved to Akron in 2019 with her daughter and her grandson and granddaughter-in-law. Her husband died 16 years ago. So for the past 4 years, she has no connection to anybody. She hasn't been able to be close with anybody, and she lives with her grandson and granddaughter. So her current living situation, her current diagnosis: she has memory loss since 2019. She has vascular dementia without behavioral disturbance, and that was diagnosed in October 2020. Insomnia, MDD, and then physically she has chronic abdominal pain, constipation, hypertension. Pain-wise, she has bilateral hand cramps, muscle atrophy, osteoporosis, and multiple joint pain and arthritis, back pain, and she has GERD. She has chronic chest pain. Fortunately, the stress test was normal. And then she has anemia. Last time she saw HEMOC was also in 2021. Medicine right now, PsychMed, she has nortriptyline, Zoloft, Namenda, Neurontin, and then the blood pressure medicine, cardiology, the heart medicine, Vasotec, and then Ventolin. She for stomach, she has omeprazole, Carafate, Miralax, and then she has iron for anemia. Pain-wise, she has Mobic, Tylenol, and then Voltaren gel, and then other liquid stuff, vitamin D and calcium. Functional status, she needs round-the-clock supervision. She has deficit in all IADL and ADL. Like ADL-wise, she can eat, toilet, and transfer herself, but like even walking, she'll need help. I think she has a walker at home, and she can't go up and down the stairs, anything. Physical impairment, she has poor eyesight, she has multiple joint pain, and then she has irregular gait. And she can ambulate on her own. Oh, I'm sorry, this is one. She can ambulate on her own. She had a walker ordered in 2020, and then she has a cane and back brace order in 2021. And from the chart review, I don't see if she has ever gotten it. She has some memory impairment, and she is alert and oriented, usually to time, place, and person. She doesn't have a lot of hospitalization, but most of them are for small issue. In 2019, she has general weakness, hypertension, and wheezing. When she went to the emergency room, I think she got cough medicine. And that time in 2019, it was her grandson that brought her to the emergency room. And he went there himself at the same time for, I think, flu-like symptoms. And then in 2020, that was her major admission. She has cholecystitis, and she had the lap chole. And she had complication after that. She went back for IR drainage. So IR is interventional radiology. So she had to go back. She has some fluid around her gallbladder that was infected, and they have to drain it. And in 2020, she had 2 ED visit for cough. And then 2021, she has some blood tinge sputum. She called 911, and at that time it was also cough. And she got cough medicine from it. Anyone have any question with the case? Good. No questions. Anything else I can add for the background? I can go ahead. Cool. So, Denise, you can hear me, right? Cool.
Yes, yeah, we can hear you.
Cool. So the primary concern, I marked it with the, how did I mark it? I marked it with the urgency I have. The 3 on top is the one that I really was stumped about. And then 1, 2, 3, 4, 5, 6, 7. The 7 at bottom, those are the cases that affects most of my patients. So I'll probably definitely talk about it in the future presentation. This issue will keep coming on over and over again. So no, the biggest thing, medication reconciliation, as telling Denise, that really bumped me out. And then communication, and then the thing with goals of care discussions, and how to help them start a DNA, and other issues that I have, her dementia, the pain management, her fall risk, her social isolation, and those are the things that I can use a lot of help and advice on. So the first thing is the medication. So like, just from what I want to see from my audience. Do you want to talk about the goals of care discussion first, or the medication reconciliation first?
Why don't we let Sue Fosnight go ahead and talk about the medications?
Okay, cool. So this this patient, the last time, I keep saying this patient, this very nice lady, her last time she saw neurology was 2020, so 2 years ago. She is on nortriptyline, Zoloft, Namenda, and Neurontin, and all this medicine are like they're anticholinergic, they call forest, they prolong QT, and I don't know if any of them can be simplified. And then for the Vasotec, it's also called, wait, Vasotec, I guess there's nothing I can do. The omeprazole, the Carafate, and the iron, they all cause constipation, and she's taking Miralax for constipation. And then she has abdominal pain too, and she has other joint pain. So she's taking Mobic, which is an NSAIDs that's every day, but it causes stomach problems, that reflux that she's taking the omeprazole for. And there's one more thing. She's been on omeprazole more than 5 years, like most of my patients, and it doesn't help her with her alendronate. So I haven't started her on her alendronate because number one, she has chronic abdominal pain, and number two, her omeprazole lower her stomach acid, and it kinds of make the alendronate does not work well. And then in addition to that, the omeprazole also causes osteoporosis and pneumonia, so it doesn't help with her COPD and abdominal pain either. I feel pretty helpless with this med list.
Okay, so my name's Sue Fosnight. I'm a pharmacist and been working with geriatric patients for quite a while. And I think you're right. I also think that you understand all the issues with these medication lists that you've have inherited here. So I think the way to approach this is one step at a time. So I agree with everything you said. The nortriptyline is probably the biggest issue anticholinergic wise. Zoloft, Namenda, Neurontin don't have a whole lot of anticholinergics, but we'll talk more about that in a minute. I have a couple students here, so we discussed this case, and I'm going to invite them to talk a little bit here in a minute also. So, but before I do that, I wanted to ask you, what is her most prevalent symptom that's bothering her? So that kind of gets us some idea of where to start. Is she in pain? Is that abdominal pain really bothering her? Or is there something else that would you say is her top priority?
So this is an educated guess because my second concern with the communication and goals of care discussion, I actually can't really figure out what she wants, but I think the polyarthralgia, so the joint pain and the ABD pain, that's what is most urgent for her.
Okay, so pain. Okay, both joint pain and abdominal pain.
Yes, and then a little thing to add, her back pain, I'm worried about her osteoporosis and her back fracture. So the alendronate is kind of important for me too.
Okay, so they're also interconnected. So one thing, I guess I'll start out and then I'll turn over to the students for a couple of the other topics, is we'll start out with the alendronate. And I'm going to start with the beginning of where I would start. So first of all, with the iron that she's taking it 3 times a day. Iron's pretty hard on the stomach. I absolutely agree. It's contributing to the reason that she needs the Miralax. I don't know if you have a recent hemoglobin or a hematocrit, but most older patients don't absorb more than, if you give more than 325 milligrams a day. They've also even shown that giving 325 milligrams every other day is about equivalent. So if we could cut that iron, that might cut down on her need for the Miralax, the Curafate, the Omeprazole, to some degree, but we have one more thing we'd have to do before we get rid of both of those. So cutting the iron to every other day and then watching it. And if it goes down significantly after you give it every other day, then it would be something that you probably can do a prior auth to be able to give it IV. So if she really needs that iron, it probably would have to be given IV. And most of the time, if a patient has failed the oral iron in a dose they can tolerate, they will approve the IV. So getting rid of the iron will then help to also, in some degree, to get rid of, I would think, the meds that are bothering her, that are helping her stomach. And one of those is the Carafate and the Omeprazole. We'll start with the Omeprazole. So there's also something connected with the Omeprazole is the Mobic. So as long as she's on Mobic, they would recommend Omeprazole as something to, as a prophylaxis. But the 40 milligrams is a huge dose of Omeprazole. I mean, that's double the dose. So if she doesn't have some underlying GI bleed or Zollinger-Ellison syndrome, then she probably could just get by on the 20 milligrams. The fracture risk with use of Omeprazole is dose related. So decreasing that dose will help to decrease her fracture risk. As far as getting then back to the alendronate, I think I mean, she has a FRAX score of 3.3% for her hip. So she does definitely qualify for osteoporosis therapy. Rather than giving alendronate, which could be also irritating to her, especially if she has any esophageal problems, but also with her dementia, sometimes it's hard to get patients that have dementia to do the things they need to do, like sit up for 30 minutes before they take the dose. So a lot of times we use Prolia, which is denosumab. And that one is kind of nice because you just give it as an injection. It's 60 milligrams sub-Q every 6 months. You can do it in the office and bill for it in the office. So using Prolia instead would be something I would recommend for this particular patient. Now I'm going to turn this over to maybe to Olivia about what you think about doing for the pain. Olivia, are you okay with that?
Okay, can you hear me now?
Yes.
Okay, yeah, and you can just correct me if there's anything that I missed. But so as far as what we talked about for the pain, you did say that she's on both the Mobic and the Tylenol. As far as if the Tylenol is only being used for as needed, what we can do to kind of help out with the omeprazole issue as well is we could take her off of that Mobic and just schedule the Tylenol. So like for older patients, we can do 1,000 milligrams TID for her. And then other things for her, she's on the nortriptyline 25 milligrams, as well as the Zoloft 50 milligrams. And like we talked about, the nortriptyline has that anticholinergic effect. We could consider switching her to duloxetine to help out with some of the pain and to kind of mitigate that effect. We'd obviously have to wean her off, and we can give you directions on that as well. And then if the Voltaren gel is working for her, I don't know where exactly the pain is, but she can continue with that. But we could wean both the Zoloft and the nortriptyline for her. And then as far as her gabapentin too, she is on a pretty low dose, only the 100 milligrams TID. So depending on how her labs are, she does have room to go up on that dose as well, if it's appropriate for her. I know we don't have that information right now, but
Is her renal function reduced, or I don't know if you have that information available to you, but
Her RFP is normal, more than 35. The Neurontin was also worried because it caused dizziness and fall risk.
yeah, it's a big fall risk. And so I'll let you finish. Go ahead. I agree that gabapentin for somebody with a decent creatinine clearance is probably not doing much. I mean, you could probably wean it up at least to with a creatinine clearance greater than 35, I'd be very comfortable with going 200 3 times a day. And I believe the max would be 300 3 times a day for her.
Okay. And then as far as pain, that's pretty much all I had.
Okay.
Is there anything that I missed?
No, I just a couple things I wanted to clarify that the Mobic, with her Mobic, if she doesn't have like rheumatoid or some other inflammatory arthritis, then the Tylenol should work. You have to tell her to take the Tylenol for at least 3 days before she decides whether it works or not. And the dose on it would be, as long as her liver functions okay, would be 1,000 milligrams 3 times a day. And to wean the Zoloft, really we would wean the Zoloft to Cymbalta. And then once she's on the Cymbalta, which helps with neuropathic pain, then when we would wean off the nortriptyline. So I could either send you separately the instructions to do that if you want me to email it, or really it's just for the Zoloft, you would switch it to 25 milligrams daily for a couple of weeks. And then you would also start duloxetine 20 milligrams daily for a couple of weeks. And then you would stop the Zoloft and you would increase the duloxetine to 30 milligrams daily. So that's kind of the wean for that. I'll write down and then once she's stable on the dose of duloxetine is when I would start the nortriptyline wean, which would be to decrease it by about 25% every 2 weeks. So I go very slow in these older, frail patients. Some references say you can go faster. And I'll basically, I have down your email address and I'll send those to you also, so we don't take all the time here. The other things that I think, Sam, did you want to comment on the sucralfate? And I think we'll be done.
Can you hear me?
Yes.
Yes.
Okay. Sorry, my power went out at my house, so
Oh,
we are
no.
having an interesting situation. Gotta love the rain. Okay, so the Carafate. I know she's probably using it for some sort of stomach upset. Do you know, was it just added in addition to the omeprazole, or?
Yeah, it is. Like a lot of our Nepali patients with GERD, our nurses just keep going up on the Protonix or the Prilosec, and then they tack on other things. I'm trying to send her to the GI for endoscopy, but it is a low hanging fruit.
I gotcha. So there's just some concerns with the Carafate. Carafate can, you're supposed to do like 2 hours with separation with Carafate with other medications, because it can interact and like cause your medications not to be absorbed properly. And with some of those, like some of the most concerning ones would be like the vitamin D, the calcium, the iron. So it's possible that those medications aren't even being like absorbed properly because of the Carafate. So it's mostly just like if she's taking it proper, like if she is doing that. And it's possible that we could switch her to something that might just be more beneficial for her, because that's generally more medication for like if you've had ulcers and stuff like that, which I mean, we don't know if she has or has not.
Okay.
Kind of where.
Yeah, that's
we're going with
exactly
that.
right, Sam. So hopefully when you take off the Mobic and the iron is a lower dose, that she might start to not have as much GI pain. And I would first take away the sucralfate. Using famotidine PRN is a way. So she could take famotidine 20 milligrams daily PRN if she has GI pain. Would be something you could do instead of the Carafate. It works fast. Most patients will get a good response from that. And she may not need any of this if we are able to get her without the Mobic. So the other thing to think about would be the omeprazole. I'll send it to you. There's a great organization called deprescribing.org. It walks you through how to wean people off omeprazole, because if you just stop it, And going down to 20 milligrams would be good, but then I would keep the 20 milligrams PRN would be what they recommend to do. And the very last thing on the meds would be the Namenda. I don't know if she has mild to moderate dementia. Has moderate to severe dementia. Didn't sound like it from your presentation, but maybe. But that one is, and it's just would want to double check the dosing on it. If your creatinine clearance is greater than 35, you can wean it up to 10 milligrams twice a day. So you're right that there's a lot to do with these meds. I would expect I would normally, you probably could do the iron and right away, do the Tylenol right away without the Mobic. I would say those are the biggest issues. Do the Prolia, but I always do these in steps. So if something goes wrong, what it is that's causing the issue. This would be something I would think it might take a few months to get to all of this, just so it's not something you can do all at once, I guess is what I'm trying to say. And you probably already know that. All right, I think that was it for the meds. Sorry to take so much time there.
Oh, it's very complicated, and I really appreciate you.
Thank
I
you.
wouldn't have known what to do.
Thanks.
Thanks so much for that. Maybe we can move on to maybe the goals of care discussion. Would that be all right?
Yeah, that one's like really, yes, that one is the one thing that I worried about for most of my geriatric patients. So this never get addressed with any of my patients. I'm sorry, this hasn't been addressed for all the geriatric patients I have seen. So like for this lady, she has a FRAX score of 3.3. So any one time of her next ED visit, it may have been like a hip fracture, or if there's anything wrong and she has cardiac pulmonary arrest or her heart stops, then she doesn't have anybody to speak for her. And I can't imagine what it's like to have someone start CPR on her. And her grandson, it doesn't look like he has a lot of, he has very high health literacy either. So I can see her ending up in the ICU for a month or two on a ventilator, and nobody would know what to do for her. That's it. In UH, where I had my residency, the social worker would help with this would at least help her get the POA. And then I have training with palliative medicine, so I can at least do a goals of care discussion, but we're not really trained on doing it in the cultural and linguistically appropriate way. And I don't know, like our social work department supervisor, she is happy to start doing it, but she hasn't figured out where we can find the training for the social workers either.
Anybody have any advice?
Hey, this is Jess Wilson. With the different medical issues with the patient and with her history and everything, would a referral for in-home palliative care be appropriate at this time? Just to, number one, look improving quality of life and patient goals, and working with the family to make the patient the best that they can be. And it's number one, it's another set of eyes and ears looking at the patient to make her the best that she can be, but it's also it can help focus on those goals, care decisions, what do they want, what do they need, and helping with that.
Jess, you're preaching to the choir. I just need some directions on how to start. That's number one. And number two, her dementia, I was telling Sue, I'm not sure how advanced her dementia is. And I was looking at the MMSA. I don't know, like, if our psychiatrist has culturally appropriate dementia screening test either.
Tell
Like,
them what the issue was.
oh, well, I was talking to Sue about the mocha. Is it the mocha? The mocha has the picture with the rhinoceros and the lion, right? I'm very sure she haven't seen a rhinoceros before. And I wouldn't know how to like get her to tell you what that is. Or like, what is the other thing? Counting down from 100. I don't know if she ever have a chance to count down from 100. Like, she's been in the refugee camp for 20 years.
So
And-
there's that wasn't even a test that was appropriate for the audience.
Right. And then number 3, like my little soapbox about medical interpretation. A lot of people like to skip a medical interpreter for the family. If her grandson says, okay, I will interpret for my grandma, you don't know how much he's telling her. And then a lot of times he's answering for her.
Mm.
And even when I have an interpreter there, she's so used to her grandson talking for her, she like doesn't speak for
Well,
herself.
What I would do, because I work with, I am on a work group for the palliative care initiative, and I do a lot of referrals for in-home palliative care with some agencies in the community. And in my notes for when I do the referral, I would put needs an interpreter for, whatever the language is, and, specify some of the issues at the time in the referral for, what's going on. And even possibly having a conversation with the point person of that palliative care agency. One agency that I use consistently is a group called Homestead Hospice and Palliative Care. I work with a guy named Andrew, who is amazing. They don't do pain medications, but they also don't take Summa care, but they do most every other insurance. But it's a nurse practitioner that goes out and evaluates the patients. They see them at least monthly, but they tailor it to what's going on with the patient. And I have a list of patients that they're working with, because the whole goal is we're trying to keep patients out of the hospital, keep them with whatever their health goals are. If they want to stay at home, they want, we're trying to improve their quality of life, but improve their health to as healthy as they can be for them. And it has worked very well. We've had quite a few patients that we've been able to meet their health goals, and then they've been able to, at whatever point, transition to hospice if they wanted to. And we've kept their goals. We've kept them out of the hospital, and we've kept them to doing what they needed to do. But the nice thing is, it's another set of eyes and ears, helping you with this patient, and seeing them in their environment. And it helps if they need, they can, like you're highlighting, the fall risk, the social isolation, if they see that they're needing home care, they can get that referral out too, to help you with that. If they need pain management, there's another group called Traditions, which is a sister company of Homestead, that is able to do the pain management. So we would actually, instead of doing Homestead, we would do a referral to Traditions. And so we've been doing a lot with, referrals for palliative care lately, with my primary care patients, because it's a huge thing, and also teaching patients the difference between palliative care and hospice, and because palliative care, we've actually, with Summa, they only have a clinic where you have to go there, and the patients I'm working with a lot, we need someone to come into the home. Getting them to another doctor's appointment sometimes is too hard.
Thank you
Okay.
so much. You're my hero. And
So we could, if you want to exchange contact information too, that's a great suggestion, Jess. I'm going to go ahead and move on to the fall risk because I know we have some of the medication issues that were discussed may at least decrease the risk of fracture with the fall, but we may have some other suggestions related to that fall risk.
So I would say with the falls risk that the things that we already talked about with the the omeprazole was more of a fracture risk, but also getting her weaned off the nortriptyline is one thing that I think would help with the falls risk. She's already on vitamin D. Another thing that I think would be important to do would be to check a 25 hydroxy vitamin D level, because both high and low vitamin D levels are showing that they increase the risk for falls. I know that the high end, we used to think of 100, and more information is coming out that you need to keep the level between 30 and 50. There was just another new article out this last couple months. Other things for falls risk that you may or may not have thought about are just things like, especially, I have found this with my Nepali patients, is making sure that their shoes are in good shape and have backs on them a lot, especially in the summertime. We'll wear sandals, and that might increase the falls risk. So just checking the shoes, making sure that they've had a recent hearing test, because not being able to hear has been associated with falls, and a vision test, and doing a foot exam and making sure they don't have like a sore or something on their foot that is causing them to walk funny. So those are things that sometimes get overlooked with the falls, but that's about all I had for that we haven't already talked about.
Thanks.
We do
And-
have a representative from Habitat here. We actually are working with them on a program that might benefit her. Does she live in the North Hill area?
I will find out. I think most of them live by Cuyahoga Falls Avenue.
So Marissa, do you want to describe?
Sure. Can everyone hear me?
Yep.
Yes.
Okay, awesome. Hi. So Habitat for Humanity of Summit County, we just recently introduced a new program called Aging in Place. And our Aging in Place program benefits seniors over the age of 60. And currently, I think I see him on our call, but Priest Good is our Aging in Place and Faith Relations Coordinator. Sorry, got to get away from the oven.
Yes, I'm here. It's just loud.
Oh, hi, Priest. Okay, great. So Priest is at our Habitat International Conference right now. So, but he is the Aging in Place coordinator that will, connect you to the application process. So really it's all about home modifications and critical home repairs. And we've extended it to seniors that live with their children, or in this case, grandchildren. So I, in the chat, put Priest's email. So you would be able to directly reach out to him to learn more about our program, not just for this patient, but for other patients, that you work with. So it's a wonderful opportunity for seniors to decrease their risk of fall, or even their fear of falling, with some of those physical home modifications inside and outside their home. Is that?
Yeah. So
good job.
actually they'll send a physical therapist, a habitat construction person, and priest, actually, right? We'll do the initial assessment. They'll look at the home and see if there are any sort of home modifications that need done to prevent falls, but it actually goes back to a team as well, another extension of our CMIT team. And then they come up with the plan, and they actually go in and do, that's what the grant is for. It actually, they can go in and put in grab bars or a ramp or whatever. So it's a really great program.
Yeah, and just clarification, Priest, our Aging in Place coordinator's name is Priest Good. So we're not sending out a priest.
Oh, I'm sorry. I didn't mean to imply that. Sorry.
Well, some people are new to the program and new to Priest.
Sorry.
So yeah, no, he's a great person. His name is Priest Good. I see a question says, who qualifies for habitat assessments? So we serve low to moderate income homeowners, or like I said, folks, seniors that live in homes that are owned by either their children or grandchildren. That's a case-by-case scenario. And then they have to be current with their mortgage. They have to have current homeowners insurance. They need to be current on their gas and electric. So these are all of the requirements that I will post a link to our Habitat home repair website in the chat box, so everyone can cut and paste it and learn more about our requirements. And there should be a link or information about to link up with Priest, sorry, and or our construction site supervisor, John.
And
That
Carol,
would be helpful. Like, and then if you do the assessment, like little things like moving furnitures and carpets, those you can let me know, right?
Yeah, so the occupational therapist will come out and basically, you know, make all of those suggestions. So we've had suggestions, Sue, you might need to jump in, but like, you know, not having two carpets, like a rug on a carpet. So that's a trip hazard, you know, moving a couch so that, you know, there's less obstacles. Or I think just we've had an idea, I don't think we've ever applied this, but painting the wall behind, you know, the bathroom, like the toilet. So just creating those physical augmentations of their living space that would enable them to live, you know, more independently. So yes, that's the whole purpose for the occupational or physical therapist to come out with our construction staff to assess the entire situation. Yep.
I
Thank
think
you.
lots of adding handrails and grab bars and things like that. Seems like that's been on there a lot.
Oh, yeah.
Yes, actually, our last one, we just had a situation where it was just actually just removing or, you know, changing the placement of a couple rugs just because they were trip hazards.
Yes. That's awesome. I was like, yeah, I was hoping someone can check on their house, and I don't know where to ask for help. So I'm really grateful. I feel very hopeful after after all your help.
does anyone else have, I know we've run over, but it's been great feedback, hopefully very helpful. Does anyone else have it of these issues, anything sort of pressing that they'd like to share?
This is Mary from Asia. I just have a question. I think, isn't it that people who are in the passport program can have grab bars installed in their homes also? That will be, I think, Direction Home.
Yeah, that would
Yes.
be the, yeah.
Yeah, actually, grab bars are covered by most insurances. In waiver is the pair of last resort. So generally, we try to get Medicaid, whatever Medicaid program they're on, that pays for that. But we can also pay for it through waiver. But again, they only qualify for waiver if they're on Medicaid.
Do you know, Sibley, if what her insurance is?
Yes, Medicaid. It's all Medicaid.
Do you know if she's on,
Yeah, definitely Medicaid.
is she connected with Direction Home or on a waiver?
No, definitely not.
Okay. She can always be referred to our ADRC for screening, and we can see if she can qualify.
Do you have the
Yes,
number for that,
definitely.
Michelle?
I do.
Thanks.
Maybe.
So
Sad that I
Sibley, they can call this number and they'll do a phone assessment, and then they'll send somebody to the home and do a comprehensive assessment of them as well to see what they're qualified for. So
What is your AVF? What's
You-
Michelle's organization?
It's
Oh,
Direction
Aging in
Home.
Place.
Yeah, Direction Home, Area Agency on Aging.
Oh, Area Agency on Aging. Aging. Direction Home.
Yes.
Cool. Thank you. That's
You're welcome.
awesome news for me.
Yeah, I can just put the phone number in the chat if you want.
Yes, please.
Sure.
Please, and thank you. Cool.
I was just going to mention also that you had talked about it's hard to get her assessed with a, as far as her dementia goes. There is something called the Mini-Cog, where you ask the patient 3 questions. You ask them to draw a clock, and you ask them what were those 3 questions. And that has been validated to be similar to an MMSE. So it's got pretty good. It doesn't give you the stages, though, is the bad part about it, but it at least tells you if the patient does have some cognition issues. And to me, that one would seem to be not as affected by culture.
Mm.
All right,
Thank
well,
you.
I think we'll go ahead and wrap it up for today, but thank you very much for this great case, Sibley, and thank everybody for their wonderful input. And hopefully this will help improve the quality of life for this person. So thank you all.
Thanks.
Thank you so much.
Goodbye, everybody.
Bye.
Take care.
Bye. Thank you.
Thank you.